So here we are, NUR203, exam 3. This is our last exam in this class. So we're going to be working into the HESIs next. So as we're going through something you don't understand, please do not hesitate. Speak up and I'll explain it in a different way if you don't understand it, okay? So head injuries in children. What do we need to know about a head injury? Well, we know head injuries are due to many reasons. Motor vehicle, of course, it's always number one on injuries. Bicycles, sports, clowning around, kids being kids, and they do have falls for whatever reason. One of the things about head injuries is how do we take care of that child that has had an injury? Well, we need to know, is it just a bump the head, it's no big deal, or is something else going on, right? So what do we monitor? What's the most important? And that is that change in the level of consciousness. Are they acting weird? Are they confused? Are they hard to wake up, etc.? That's telling you a head injury is getting worse. That means there's bleeding going on in the brain. It's pushing, and it's creating that change in the level of consciousness. Any child that or adult at that can matter that has pupillary changes. So all of a sudden they're getting doubled, blurred visions, or a pupil that's dilated, fixed. Those are now telling you that there is a neurological emergency. So change in status, level of consciousness, the way that they're walking around, etc. These things should be followed up, call a doc, get them in there, or it could be a surgical emergency. When we have a child discharged, and especially when we get into the teenagers, remember children who have had a status post concussion for whatever reason, they've bumped their head hard. These children, we don't know when this level of change of level of consciousness can occur. These children should not be driving until they get a clearance because they can all of a sudden, be driving and then they can be a danger to themselves and to others. So what's important? That change of level of worsening level of consciousness. And then, lack of oxygen getting to the brain. There's blood filling up in there instead of, a brain tissue there. You're not getting oxygen. That's going to be that restlessness. That's that confusion, difficulty to arouse. Vomiting with no relation to feeding. It also is brain tumors, the same thing. Vomiting, and now it's getting worse. Headaches that wake them up when they're sleeping. Usually headaches once you're asleep, they don't wake you up, but it can. Of course, that blurred vision, trouble walking, and as I said, that fixed dilated pupil is that neurological emergency. It's telling you the brainstem is having something going on there. And if we don't relieve that pressure quick, it'll be a permanent neurological injury to that child. So traumatic brain injury, or TBI, in infants, they can happen for many reasons. They could have fallen off of changing tables onto their heads and stuff, right? So how do we assess an infant? Well, the easiest thing, of course, is that fontanelle. Fontanelle's there, and it should be just sitting there, flat to the head, level. And if they're crying, it might bulge a little bit. But if they're just sitting there and their fontanelle is bulging, we have increased intracranial pressure. Also, that pressure in the brain can push down to the brainstem, which does monitor your heart rate and blood pressure. So bradycardia is a lot of pressure going on in there. And then those scalp veins that those infant has, they're going to get bulgy. It's telling you there's pressure going on, that brain's swelling up for whatever reason. Now, meningitis, there are two types. We have viral and we do have the bacterial. Bacterial meningitis is the one that we're really worried about. So how would you know bacterial, viral? What's the difference? Well, of course, we're going to do a lumbar puncture. Even if we know in the end it's viral, we can't rule it out until a lumbar puncture. What do we see? Well, the lumbar puncture is going to have fluid that comes out. On bacterial, it's going to be milky looking or cloudy. A viral is always clear. because what is those white cells? That is what's causing the milk, the white blood cells in there, and that's bacterial. Also, when we look at it, we measure glucose and protein. Bacteria love sugar, so it eats it up. So the glucose is low and it leaves protein alone because it likes the sugar. So proteins are high. And that's how I remember both of those. Remember, after a lumbar puncture, they can get a spinal headache, just like spinal anesthesia type thing. So again, getting them up slow and easy afterwards, and they should be drinking fluids in order, to replace that fluid. So they say about 30 minutes to prevent that spinal headache. Now, child with a meningitis. Now we're saying antibiotics. So this is your bacterial meningitis. Your priority in these children is to give them their antibiotics. Now, any child that has been diagnosed with bacterial meningitis will be on droplet isolation for 24 hours. Okay. Once they've had 24 hours of antibiotics, then they can come out. Then they're safe. Okay. Our goal with this children is their head hurts. They, lights, sounds all bother them. So that's why minimal stimulation, and you're going to cluster care. Go in, do what you need to do, and get out because that overstimulation can cause seizures. Now, many a times with meningitis, there's an increased risk for cerebral edema. Now, we'll be noticing that by the extra headaches going on, vomiting, it's telling us it's going on. So how do we treat cerebral edema? Well, edema is fluid. So we give them a diuretic, right? Now, the diuretic is the one specifically for brains, and that's going to be your mannitol, all right? Also, what we're going to do is most of these children are lethargic and they're sleepy. We're going to be monitoring intake and output. We can actually put their heads into more swelling and discomfort and more damage just by giving too much fluid to them. So carefully monitoring intake and output. No fluid overload for these children. So again, what are we going to do? Monitoring, same things, right? Monitor change of level of consciousness, lethargy, headache, repeated vomiting, and of course that bulgy fontanelle. And your infant will be lethargic and not even really wanting to eat. And that's usually a clue to what's going on. Now, hydrocephalus is water in the brain. Somehow the conduction pathway between the meninges and the brain and down the spinal column doesn't work well. And it just increases the fluid. I don't know. It increases the fluid into the brain and it swells. And again, it's causing all the same things that you're seeing. You're going to have that headache. You're going to see that, level of consciousness, all of those things. So when you're talking about usually hydrocephalus in infants, we do a daily. They're in the newborn ICU or in their nursery. We're going to be doing a head circumference every shift and an abdominal circumference with every feed. And it's because we're making sure that this child's not filling up in the brain with any sort of fluids. One of the things, the Mesa wind sign, is a sign to detect hydrocephalus and brain abscess. So they're saying if you tap certain areas, we can tell that it's either a hydrocephalus or a brain abscess. Of course, and it's this, unless you've been skilled to do that, it would be the physician that will do it. And then, of course, the eye, sun setting in the wrong way. And of course, always vomiting headaches. So many children get a VP shunt put in. It goes into the fourth ventricle in the brain, behind the ear. There's a pump there, but we do not touch that thing. It's only for the neurologist, the neurosurgeon. And it goes down the front of the chest into the peritoneal cavity. And it just keeps that fluid moving. Many times they come in, and what is happening? They're complaining of vomiting and headache. And we know there's something wrong with that shunt. All right. So this is something that we teach them. You see these things, please come in. there's a problem that could be going on. Now, you have a child who's comatose. How are you going to assess the pain? Now, you think it's doesn't happen, but children sedated, paralyzed, sedated, or comatose. These children, their heart rate and blood pressures do elevate when they are in pain. And if they're not that paralysis there and they're just sedated, you'll see them getting stiff up. They're tensing. It's telling you something's happening. Now, neuroblastoma versus a nephroblastoma. So we learned about a nephroblastoma, and that is the Wilms tumor, right? That's the big one that we worry about. Don't touch the belly. And we did test that on the last exam. Part of it. Now, any tumor that is the neuro or nephroblastoma, both of them can affect the blood pressure. So part of the treatment plan, if you have a child with in the brain or in the kidney tumors, we're going to be monitoring blood pressures really, really closely. Now, sometimes they do need medications, and we're going to give something as simple as an allopril. We can use an ACE inhibitor or a beta blocker, but the enalapril seems the one that works really well in controlling that. Now, seizures. There's all different sort of seizures, right? What can they be due from? Well, almost anything can cause a seizure. Fevers, of course, we know febrile seizures, infections, hemorrhages, metabolic problems, trauma, a malformation in the brain, genetic disorders, and of course, anything toxic that comes in. So anything, almost. There are all different types of seizures, from a blank focal stare up to the tonic-clonic. Now, tonic-clonic is the one we talk about seizures we really got to be concerned with. And that is that generalized, that old grand mal, they used to call it. And that's that extension, flexion, and they're violently shaken and they lose their level of consciousness. They might foam at the mouth. This is the one that we got to do all of those things to be keep them safe. So you see a child, you walk in, no matter if it was a febrile seizure or a child with epilepsy having a seizure, make sure when you go in, the first thing I do is I walk up, pull the side rail up, clear the bed, because kids love every toy in their bed, don't they? And then they're going to be, scraping against it with these movements. Their head should be flat, the head should be down, and you turn them over on their side. Okay, when you turn them over on their side, it's in case they vomit, right? And of course, suction there. If they're vomiting on their side, you keep that area clean. It's not to put in their mouth, it's to clean the area around there. And remember, if the seizure goes on, doesn't stop, we're going to need an IV and we're going to need some sort of medication in order to take care of it. Now, one thing that we forget, and I know I'm one that could forget to teach it, these children can have a seizure. And if there's somewhere where it was dangerous, like out swimming in the middle of a lake or an ocean, nobody's there, has a seizure, that could be dangerous, right? So we need to make sure we teach these parents that keeping them safe. If they're going to be somewhere, could have a seizure and it could harm them, make sure somebody is with them at all times. Now, pituitary dysfunction. We know that we have a fluid side, that's your posterior side. And the anterior side's all about growth, right? So when we talk about hyperpituitarism and we talk about the growth side, the anterior side of the pituitary gland, growth hormones are given to those children who are short, but their families aren't. They'd be taller, okay? So if a child wants to get taller and the whole family's short, giving in injections of a growth hormone is not going to work. So with hypopituitarism, they're too short, families are taller, they want to try the hormones. It is a subcutaneous injection every day. It's like being a diabetic. It takes a lot of commitment. from parent and child to make sure that they get that injection every single day. Now, how would we know that the growth hormone injections are working? Well, what do you think we do? A height and weight on every visit we see a child. Urgent care, doctor's office, doesn't matter. We're going to be doing height and weight. We're measuring the effectiveness of the growth hormones. And, getting a subcutaneous injection every day, and they could be on that for a couple of years. They say to stop it when you stop growing or the growth is less than 1 inch a year. Then they say, nope, that's it. They're not going to grow anymore. Now, diabetes insipidus, this is the posterior side. This is all about fluid balance. So diabetes insipidus is where you have nothing to do with the blood sugar. Nothing. Not at all. All it has to do is with fluid balance in your body. And when you have that cardinal sign is where they start drinking, urinating, and urinating, and they are upset, especially infants. Sometimes we'll find it as an infant, and they're irritable and they want to eat and they keep drinking and still nothing is relieving. The thing is, you give them a bottle of water and you're going to see them be happy with water, not milk. Okay, that's usually okay. Now we need to test for diabetes insipidus, and we also know that we could take away everything by mouth, and the urine's still going to keep urinating. So diabetes insipidus is 2Ps. So what do we do? Well, we're going to be taking a hormone replacement. There's a DDAVP. There's a vasopressin, right? Vasopressin we've talked about with bedwetting. It works there. And they do have the nasal, they do have subcutaneous, and they do have IM injections, and it is for life. But there's nothing to cure it, but we can take care of it. So getting their hormone every day, watching their INO, of course, monitoring their daily weights, which of course is all about fluid balance. Now, sometimes they hold fluid, right? Diabetes loses fluid like crazy. There is the syndrome of the inappropriate antidiuretic hormone, SIADH, which is they hold on to all the fluids. So this child is going to be swollen, generalized edema. So how do we take care of that child? Well, we're going to be monitoring, and fluid balance is always monitored by intake, output, daily weights. These children will have fluid restriction and salt restriction to make sure that they're not just continuing to gain it. Now, diabetes mellitus. This is 3Ps. So they're thirsty and they're urinating, but polyphagia, they're hungry. Why are they hungry? Well, the sugar in the blood in the body is not being used. They don't have insulin, it's not broken down, the body doesn't get it. The body says, I'm hungry. So that's why it's 3Ps. Because they're not eating and digesting sugars, they're not getting all of that calories. So they're going to lose weight. They're going to be tired because they're not getting that energy. And you might even see bedwetting at night, might be the first clue that you see on a young child that has diabetes type 1. Okay. Now, we do measure diabetes with a hemoglobin A1C. They let children's hemoglobin A1C go to 7, and blood sugar is not 100, it would be 126. So diabetes mellitus is a chronic disorder of metabolism characterized by what? High blood sugars, hyperglycemia, and insulin resistance. It's just not working, and the sugar just sits there. If you have a mother who is diabetic and you get their infant to monitor afterwards, you have to be careful. These infants will have frequent blood sugar monitoring because you're at risk for low blood sugars. Another thing is you have an adolescent. It's one of those questions, actually, that came from a concept on a HESI about you have an adolescent who is a big person, 92% BMI, and they've been urinating. Well, what could it be? Well, urinating could be diabetes insipidus. It could be diabetes, right? Or it could be a urinary tract infection. And of course, we're going to make sure that we check all of that urine going out, potassium results too, right? So think about the whole picture. Where could it come from? So TKA, what happens? Something happens that the insulin is not working at all, and the blood sugar elevates and elevates because the sugar is not used, and the body says, I'm just really hungry, and I don't have this insulin to digest my sugar, so I've got nothing. What am I going to do? So the body says, let's go to the fats, let's go to the proteins, and let's start eating them. So it's taking another body source, protein of fats, and trying to get the nutrition that they do need, right? So ketonuria, that does replace the hyperglycemia. So if you see a child, elevated blood sugars, not looking good, a little bit lethargic, pale, you're going to do their urine test. There'll be 4 plus glucose, 4 plus ketones in it. And now you know that this child is in diabetic ketoacidosis. So you'll see things like they're drowsy, decreased level of consciousness, that skin turgor, they look dehydrated, they're going to be oozing so much sugar from a blood sugar. You ooze it. You can smell it in the room. And of course, they'll go to hypotension, bradycardia, if we don't correct it and get that sugar being used. Now, what is the opposite of too much blood sugar? Is not enough. It could be because they took their insulin and didn't eat, right? So that nausea, vomiting, jittery, restless, shaky, sweaty, dizzy, all of those things you might see. So what can you do? Well, you need to give them some sugar right now of some sort, whether they have those little commercial sugar tablets, and they say they taste pretty good, or how about a candy, a hard candy? If you have orange juice, of course, sugar is fine. Um, milk is good. And then honey. But remember, not till the age of 2, because they can get botulism on honey, right? Now, a conscious child can drink those things. So if they're telling you they're weak and dizzy, they're alert enough to say that. An unconscious child, you're going to give them the IM glucagon, and always remember, turn them on their side, they will vomit. It's just guaranteed. Now, adrenal problems. We have too much, too little. It's all about the cortisol or steroids in the body. Cushing's syndrome, it's uncommon that the adrenal gland is going to be causing this cortisol problem. It's usually by taking, steroids for whatever condition that it could be. We know that cortisol is there, and a lot of what we call protein wasting occurs. And the reason why I mention that is where are all your muscles and the protein, your arms, your legs. Now, they've got big faces, they got big pendulous abdomens, but they got skinny little arms and skinny little legs. It's just part of that whole picture of it. That red, ruddy cheeks, it's like redness. It's more than just a slapped face, of that viral slap face syndrome. It's red in there. Another thing, you'll see young children with little hair on their chinny chin, where they shouldn't get it. And of course, with Cushing syndrome, and as I said, mostly children, is all about taking steroids of some sort, prednisone, the big one. You're going to see them that puffy, gaining weight is a big thing. I remember body image is big with that. But too much steroids, remember, for wound healing, you got to watch for that. and there's going to be bruising going on there. So be careful with steroids and children. Now, how do we turn that around? Well, if they're taking steroids, we taper them off slowly, and actually we can take away the weight and take away all of that big moon face and that abdomen slowly. Now, another adrenal is not enough. And this is about your sex. What is my sex? Am I a boy? Am I a girl? Now, children that have not enough adrenal hormones, cortisol and aldosterone, don't know if they're producing a boy or a girl. I've actually seen only one in my entire career. And I remember seeing testicles and a vagina and a prominent clitoris. And what they have to do is, number one, they need to assign what sex they're going to be. Electrolytes, the sodium, potassium, of course, need very, very close monitoring to them. And they also got to figure out, what they're going to do with the outsides. Are they going to, change in plastic surgeries, future? But always remember, they are sterile. They will not have children, whether made a boy or a girl, doesn't matter. They do not have the parts in order to have a child. And we treat it with hydrocortisone, prednisone, which is your cortisol. Now, thyroid. Thyroid, too much, too little. Too much is Graves' disease. That's your ophthalmos, the big bulgy eyeballs that you might see. Now, Graves' disease, hyperthyroidism, is when your thyroid produces too much thyroid hormone. And we can give a medicine. There's a couple we can give. The one that we mentioned in exams and whatnot is prolithiazole, and that's PTU. And it has a side effect. And the side effect is fever and sore throats. And it's leukopenia, or lack of white blood cells, which is what? You get sick. So if children on and adults get sick when they're taking this prolithiazole, this PTU medicine, they need to call the doctor to make sure it's not the medicine causing it, but they are sick. Well, the thing about another thing about thyroid disease is normal thyroid, too much coming out, we can, get rid of the thyroid gland, and we can have them on thyroid hormones for the rest of their life. We're having a lot of problems with too much hormones being administered. So this is one thing that is a treatment. The thyroid storm can happen two ways, whether it's the hormone itself, the thyroid hormone itself is being overproduced, or let's say we double dose this child. And it's everything goes up, heart rate up, blood pressure up, tightness in the chest, shortness of breath, and it's really life-threatening. These children need to get into the ER, they need a beta blocker, and they need it, calmed down immediately. Or the elevated heart rate, etc. And they usually, if this is happening, they're going to be taking that thyroid out pretty soon. Now, hypothyroidism. We sometimes find this at birth. This is the one that at birth, they don't have a bowel movement in the first 24 to 36 hours. This is one of those that we might see at birth that we had no clue before that. Now, as they get older, if born with hypothyroidism, these children need it for cognition, to be alert. Thyroid is the same as adults and children, but in children, it's all about cognition and growth. If you don't have the hormone, they're going to be smaller and they're going to be behind on all their developmental milestones. So dry skin, constipation, dry hair, sleepiness, puffiness around their eyes, all of the things you see with adults, those you see with children. Now, treatment, we're going to give the medications in the morning, because if not, it's going to keep you awake, because it gives you like an up. We're going to increase fluids with these children, and we're going to increase diet, because again, these are prone to constipation. So we're going to fight against it naturally. increase the fiber. And that's the picture that's showing you all the differences. Now, vomiting in children. The one thing we're concerned about with vomiting, diarrhea, fluid loss. And we're worried about dehydration. Remember, dehydration in children is life-threatening. It can cause you to go into kidney failure. It is serious to monitor closely. So what do you look for? Well, infants are easy. Fontanelle is going to be sunken really low, and you're going to see the eyes sunken in the head, and they're going to cry, and there's absolutely no tears coming out. It is so sad. Now, that's an infant. And then add on the stuff that all of us have: elevated heart rate, low blood pressure, prolonged capillary refill, decreased urine output, skin tenting, all signs of dehydration, okay? So if a child's vomiting, you can't give them rehydration therapy if they're just vomiting and vomiting and vomiting. That child will need an IV. Remember, as you start the IV, you need to have a metabolic profile. I want to know my baseline. Where is my sodium, potassium, chlorides, my glucose? I want to know where everything is, right? And we're going to give that IV, and we're going to give a bolus. Remember, we never bolus with anything with sugar, and we never ever bolus any IV fluids with potassium in it. And we will not add potassium to the maintenance IV until we have the lab results back, knowing where that potassium is, and or if they urinate, if they void, okay? So vomiting, you keep them MPO, you bolus them at fluid, and remember, always protecting them, safety vomiting. If they're vomiting, have something there for them, suction at bedside, and turn them to the side if you need to. Now, reflux. Many infants have this where a little bit of their milk goes up and down up their esophagus and it burns. The problem with it burning and go esophagus is not always that burn, it's that little bit that goes into the lungs and you're having mini aspirations. That is our biggest concern. So in infants, what do? Well, we medically manage it first. Let's thicken up the milk first with some rice cereal. Whether it's breast milk or formula, we can add it to both. Make sure the family is not overfeeding them, that they're burping them well throughout the feeding and afterwards, and then making sure they're sitting up after their food, not put straight down to go to bed after, because they will reflux then. Older children, we're going to manage them. Those are the kids that they are having this chronic cough and complaining of burning in their chest. That is just classic heartburn. I mean, the older person too, right? It's that cough and it's that heartburn, you're refluxing. So how do we treat it? It's that bland diet, no overeating. You know, it's easier not to overfeed a child than it is an adult. An adult, when they're hungry, they're just going to eat, right? The other thing we could do is something called a Nissen fundal plication, and that's the surgical point where we'll take the piece of the stomach and flip it over so that they can't vomit. So now we've prevented the aspiration. We do those routinely on every gastrostomy tube we place because we put big amounts of fluid in quickly, relatively, so we don't want it to reflux. So we hold it down by doing a surgical intervention. Now we have the reflux, which is the dribble, right? First question I ask, you have a young baby, they're 2 months old, coming into the ER, they're vomiting. All right, are they dribbling or is it across the room? They tell me it's across the room. This is absolutely pyloric stenosis. It is projectile. You can point this child across the room at a garbage can and they can hit it. It is that forceful. So what would you do? I take my hand, put it underneath their abdomen, right in the mid, underneath the xiphoid process, to the right or left, the middle. It's right there. You're going to feel a marble size or an olive size hardness. That is the pyloric sphincter on your stomach, which is thickened and muscular. And that's what's causing milk not to go down into the intestines. Now you've made your nursing assessment. They go over for ultrasound, and now it is confirmed. As soon as we know that that's a pyloric stenosis, don't let them eat anymore because they're just going to vomit again. And we want that stomach empty to do surgery. So this child, preoperatively, NPO, IV fluids, and that is to maintain fluid and also blood sugars. Infants, and usually pyloric stenosis is somewhere between 3 days, 7 days, and 3 months. I mean, it is just the tiny little infants, and they lose their blood sugars really quick. So they need a little bit of maintenance fluid with some sugar. Hepatitis, another GI problem. It feeds the liver, feeds bile into the common bile duct, and it's good for digesting fat, right? We know there's all sorts of things of good, proper hand washing, et cetera, et cetera. But we do universal precautions for everybody. We treat everybody, the same there. Now, diet, child hepatitis, problem with the liver. They can't digest fats. The bile's not getting to where it needs to go. So you want low fat diet. Fat, if we don't digest it, it's going to cause really bad bloating and abdominal pain. So high protein, high carbohydrates, and this is to help keep that child with nutrition and to avoid weight loss, okay? Fats are high calories. And if we can't get them, we need to at least do the proteins and the carbohydrates. Milk, fish, fruits, vegetables, and milk are great choices that we can use.
Well, it'd be nice if I asked Michael.
Celiac disease is another GI problem, and it's all about gluten intolerance. And fat is not metabolized again. So these children cannot have wheat, barley, oats, or rye. You've got to be careful, especially with toddlers, with chicken nuggets, breaded coverings of things, macaronis, breads. You've got to be careful. If they eat it, they've got severe abdominal pain, and it hurts them quite a bit. And they eat fat. What happens? They pass this bulky, extremely malodorous, very bad smelling stools. So they're not getting fat either, right? And the result of fat malabsorption, steatorrhea. It's just passing right through, and including all of their vitamins gone too. Now, they do have a lot of rice type of flours now, but it's a great substitute. So it's something they could use. They can have all the dairy they want, ice cream, chocolate, meat, fruits, vegetables, but they got to be careful of all of the wheat, barley, oats, and rye things. Remember, this is forever. It's nothing that's just there and goes away. This is lifelong. Now, food allergies, is you take a food, you ingest it, your body don't like it. Remember, for instance, your lactose intolerance. That child is not getting vitamin D and calcium. So we have to remember these things in order to get them the foods that they need. And that was the purpose of that slide. Now, Hirschsprung's disease. This is another one of those things that causes at birth, 24 to 36 hours, no stool. It's also called a megacolon. It's when the intestine is big and gets bigger and there's no nerves. So there's no peristalsis. Food can't move down and it gets stuck and it doesn't hurt. So they can't tell you. They tell you because there is no stool that's coming out. Now, times there's a little bit of ribbon stool, and you see that little tube hanging down. It's like squirting out, a frosting on a cake. It's a little ribbon something. You may see that. So what do we do for Hirschsprung's? Well, we go in, we diagnose it. There's no nerves, with a biopsy, and we're going to take them for surgery. We can either take it out, that bowel that's not functional, and have a colostomy. And sometimes we do a pull through where we take that piece out and we connect it in one surgery. So they never ever end up with a colostomy. So it's either a 1 or 2 stage thing on that. Know that anytime we have Hirschsprung's, these children have had issues with their lower intestines, no rectal temperatures. And these children, because we have manipulated their bowel so much, they have to be NPO for several days. And usually when we start to hear the bowel sounds going again. Pinworms, bugs, kids love to go into the outside and play in sandboxes in the dirt. And, worms are laying their eggs everywhere, gets underneath the nails. They put their hands in their mouth. And now they're at night and they have this intense perianal itching and scratching, and they can't sleep. So what do we tell the parents to do? At night, go in with a flashlight with a piece of Scotch tape and put it on the anus. Make sure it's tight and then pull it off. And you'll get a little tiny little worm. Put it in something, carry it to the physician, and they will confirm, yes, that is pinworms. And there's medicine they take. Now, usually, one child has worms. It could be the whole family. So the whole family needs to be checked for it. And the treatment is you can't keep a kid from putting hands in the mouth. You can't keep them from playing outside, getting into these things. Keep their nails short. There's no place for those worms or eggs to hide. Tracheoesophageal fistula. This is different connections that are they're not doing what they should. You're not connecting your mouth to your stomach through the esophagus. The atresia, nothing. It doesn't connect. And then tracheoesophageal fistula is a tube connecting esophagus to trachea. Anytime you eat or just swallow your own mucus, it goes down, it goes into your lungs, and you gag and you choke and you cough. And it's usually that gagging, coughing, and choking at birth which alerts us to this could be this case. These children need to not have anything by mouth because they literally are swallowing their own mucus. It's going into their lungs, but it's mini aspirations. And now you have aspiration ammonia going on. So what is our goal? Well, elevate the head of the bed, have suction there in case they're foaming. Of course, you want to keep it as clean as you can. Nothing, 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 nothing by mouth. Not a little anything of nothing. Any liquid in the mouth, they're going to swallow. It's going to go into their lungs. Now, pyloric stenosis, we made them nothing to eat, NPO, and IV fluids to give them the fluid they needed and the dextrose. Same here. But because of the many aspirations, these children will be on antibiotics. And it's because we are preventing as much aspiration pneumonia as we can, and it's preventing them from getting a pneumonia. So antibiotics are added on here. And one of the developmental things that we've learned, any child who can't eat, and this is the classic one, give them a non-nutritive sucking device, your pacifier, because they calm themselves that way. They explore the world in their mouth and they calm themselves. So we want them, that soother there, for them to be able to calm themselves. Appendix, just like adults, right lower quadrant, McBurney point, getting that pain, we're going to be doing an ultrasound and we confirm it. This child, it's classic. If they're walking, they're bent over, holding their right lower groin, and they're limping on the right side. You're like, oh, that's an appendix. So what do? Once you suspect, it's an OR case, make them NPO. And we're going to start those IV fluids. If they've already done the ultrasound, it's been confirmed, we usually will give a dose of antibiotics and any of their pre-op meds that they need to take, they'll be taking it pre-operatively. Now, many times, all of a sudden, right before they go upstairs, they goes, "Oh, my pain is all gone. I feel better." The appendix has bursted. But what happens is that appendix has burst all of this terrible debris of stuff into the peritoneal cavity, and now you're with peritonitis. This child, post-operatively, is going to be NPO. They're going to be on IV fluids and priority again, antibiotics. They also are going to have an NG tube because that NG tube is going to keep that GI tract free from mucus and irritating this bowel that's already angry, angry, angry. Of course, we're going to look at those white blood cells, looking at all those values, make sure they're okay, and of course, pain control. Now, one thing most students forget is that peritoneal cavity is infected. And we've gone in and cleaned it out in surgery, but we've closed the wound. That is a dirty wound, we call it. And the chance for that to dehisce is quite large. So make sure that we assess that wound, make sure it hasn't opened up. Get these kids up, get them out of bed, get them ambulating after we medicate them for pain. Give them good pulmonary care. I've done things like blowing bubbles, having a bubbles day, who has the most bubbles, or getting one of those pinwheels that you can blow. I've even taken a straw and doing little things where you do these little spit things into targets on the older kids. And oh my goodness, it helps their lungs be good. So again, making sure that we do that because their peritoneal cavity is tender. It hurts and they don't want to take deep breaths. So we need to do everything we can to get them to breathe. And omphalocele, there's many different names for them, depending on what's coming out. But an omphalocele is where the midline didn't close, and some of the inside organs are up in a sac on the outer portion of the abdomen. And it's okay. Everything still works. Our goal is to keep that child free from infection and keep the skin integrity of that area. What they do is surgery comes, and they're going to, after we put a nice wet normal saline dressing, sterile on it, surgery will come in and make their own thing and slowly will tuck it in. When they think that belly has enough room, they'll go into surgery and then they will close it up. How do we take care of that child? Until that, we're going to protect that skin. We're going to keep them warm on a warmer. They cannot be on their abdomens. They need to be on their back for sleeping. And no putting them up, swaddling them in blankets. We can't do that. We need to have them on their backs. And antibiotics are preventative again, right? They don't have an infection, but we're making sure because we want to get that outside organs placed back in. So NPO until it goes back in, IV fluids, and of course those antibiotics. Meckel diverticulum. This is that part of the duct hasn't closed, and there's this little piece of tissue in the small intestines. And in that little, what I call this outpatching diverticulum, it's like a little skin thing. And in it is a big blood vessel. And sometimes it tears. And when it tears, you will see bright red rectal bleeding. And it doesn't hurt. It's like all of a sudden you look at the toilet and it's red. You're like, okay, what's going on? You might see a little cramping, a little tenderness, but really not much. They do surgery, and these kids do well. Now, nephrotic syndrome, nothing to do with kidney failure. The kidneys work. Nephrotic syndrome says, protein, I don't like you, and I'm getting rid of you. And it urinates all your protein in your body out. Okay. So what do you see if all your protein is being urinated out? Well, massive proteinuria. The protein in your blood or your albumin, same thing, protein, albumin. It's going to be low. You got to be careful with drug dosing there. You're going to have elevated lipids in the blood and generalized edema again. So this is a child that we are going to be monitoring fluid balance. When you see edema, you think about fluid balance because we need to monitor, is the fluid going away? So intake, output, daily weights, and salt restriction, fluid restriction, just to make sure that we're not getting too much fluid on them. These are treated with steroids, and that helps it decrease. But again, nursing diagnosis, daily weights to assess excess fluid volume related to excessive protein loss in the urine. It's a great diagnosis there. They have explained it all. Now, a strep infection causes something called acute glomerulonephritis, just like rheumatic fever. Same thing, a throat strep infection that wasn't treated completely. What would this child look like? Well, they'll be oliguric. They're not urinating again, and they're swelling up. And because of kidneys and all fluid, they're going to be hypertensive. And these children have periorbital edema. Because of hypertension, they're going to have severe headaches. So we'll be monitoring blood pressures very, very closely here. And we might need to give medications until we get this cleared up. We might see bleeding in the urinary tract, and we're going to be seeing some protein in their urine here. It is, again, another fluid balance thing, right? Daily weight, intake, output. And because it's in the abdominal cavity, what we're going to do abdominal girth measurements. Again, low sodium, fluid restrictions, and these children are susceptible to infections. How do we get rid of it? Because we can. Long-term antibiotics. And they say it's not chronic until it's been around for over a year. So we've got a little while to get it clear as soon as we start seeing these symptoms. And as soon as we start treating that strep infection, the better the child will do. Now, a renal biopsy. These children will be sedated. You have to lay still and comfortable, and they'll be on their bellies, usually, or at least on their side. And they'll have them on the stretcher. Of course, as nurses, we'll be monitoring vitals before and after. They take an ultrasound, they find the kidney, stick a needle into the kidney, and they'll get a little bit of tissue and urine. And that's to look for malignancies, to look for infection that we don't know what's going on. Now, just like a cardiac cath, where we're worried about urine coming out, blood coming out, or cardiac cath worrying about bleeding like crazy, these children will have a pressure dressing on that area where they pulled that specimen from. So make sure we monitor it. We also, because it's in the back, and they'll be on their belly usually afterwards, talking to the parents, watching TV. Look at the abdomen. Is there pain? Is there tenderness? And of course, monitoring intake and output is going to tell you, are the kidneys working? On the infants, because the kidneys are small, it's hard to find. Many times they're going to have to do a surgical incision on them. Now, renal failure. Renal failure is when your kidneys do not produce and take the urine off the way it should. And we know that our goal with renal failure is whichever way, whether it's hemodialysis or peritoneal dialysis, is to promote that kidney to work as best as it can. And that's to maintain fluid and electrolyte balance. Remember, the kidney has to do with erythropoietin and red blood cells and hemoglobin. So many times they don't have enough of their own. And we do give erythropoietin injections, okay? Now, we do, of course, always in any disease in children promote normal active lifestyle, but we know kids on hemodialysis 3, 4 days a week. They're 4, 5 hours a day on it. So it's difficult. But if you're a dialysis nurse, you're going to do some great things in order to keep those kids entertained. I've seen kids learn how to play guitars with the nurses and singing and doing YouTube videos. I've seen them do things like painting and needlework, things to keep their minds going and being kids. Now, peritoneal dialysis is what we have to use for your infants. Little infants cannot take hemodialysis. That flow from the dialysis machine is too much, and it goes in the brain, and it can cause little vessels to hemorrhage. So little leaking of brain blood in the brain. So we can't do it. So what we do is we use their peritoneal cavity as a kidney. And that kidney, how do we do it? Well, that picture in that bottom right has your catheter. And sterile procedure, even just to hook up something to the end of it, you are in head to toe completely covered. Okay, just like you're going into the OR. I mean, it's that intense of sterile procedure. And they take and hook up a some sort of fluid called a diastolate. And it's hooked to the machine, and it's warmed, and it's little bit 100, 150 mLs will go in. It'll sit there, and then it will be drawn out. And each one of those fluid in, sit there, and out is called a cycle. And we do 8 to 10 of those every night. So while this child's asleep, this is running. So the kid can have a normal daytime. Now, what is our concern? That's our only kidney we have. There's no other choice. We must make sure that that abdomen does not get an infection. So any signs of it, redness, tenderness, changing of fluid of that drainage, make sure we call that doctor immediately. And they will order antibiotics. There's not a standby antibiotic order. You need to call the doctor for that. Scoliosis, S-shaped curvature of the spine. Remember, these are those pre-adolescent girls and boys, and they really have that body image thing going on, right? And they have to wear, most of them, up to about 45. It depends, 40 to 50. It's that rate area where they're going to be doing their brace 23 hours a day. They take it off to bathe, and then they should wear a cotton t-shirt underneath, and that's just for skin breakdown, okay? No lotion or powder underneath those things, just the cotton t-shirt and the brace. And then what they do is they do some really intense physical therapy. They're trying to strengthen their core, and usually that's all they need, and their S-shaped spine will get the best they can. If it's above 45, 50 degrees, they'll be doing the spinal fusion surgery. They could call it Harrington or Luke rods, spinal fusion. It just depends on the physician. It's just trying to get that spine as straight as we can. And this is the one post-op you're going to be log rolling. Dysplasia of the hip. Baby's born. What does the pediatrician do right away almost? Take the knees up and out, right? Looking for them to move, looking for the clicking sound going on, looking to see is one limb shorter than the other? Is the gluteal folds one higher than the other? Because the hip is up here, it's not here. So one leg is shorter by that much. So you would see it. You're going to see the positive Ortolani, positive Barlow. So we initially, now remember, neonates, that's your little kids, they heal really quickly. So our goal is to find it immediately, get that Pavlik harness on, and hopefully it will get in there quickly so that we don't have to go any further with care for it. That Pavlik harness does an abduction of the hip. And that word is important, that abduction of it, trying to get it back to where it needs to go. Again, 23 hours a day, off for bathing, cotton shirt underneath. Make sure you're checking underneath for breakdown, massaging those areas because infants can't, looking for redness and breakdown. And then if this doesn't work, we can put on, this Bryant traction. And there's the picture of it down below. That's for children up to 30 pounds. That means they're bigger than your infant, right? It still is not where it needs to go. And the same sort of treatment. It's 30, actually, so the time we'll just take them off once a day, rub the area, check for any irritation, and put it back on. And kids can go home on those things. Fractures going from simple to spiral. Simple is a normal one. They fell down. You don't see anything, but inside the skin something's there. So it doesn't break the skin. The one that requires more attention is the compound, and that's open. The bone is seeing the air. That means you need antibiotics. If we don't treat it, it could cause osteomyelitis. Complicated is like a fractured rib. It can go right through your lungs. That's another organ it could damage. Comminuted, it's just cracked and there's multiple pieces, creating a lot of pain and because it's all of the muscle and nerves that it's hitting. Avulsion, I call this the Achilles one, where the bone pulls away from the tendon or ligament. And then spiral fracture is something we see in child abuse, where they take the kid, hold their hand and pull it quick back the other way, and it like cracks in a spiral way. And that's how you would start. Well, it could be, let's make sure and let's protect our child. So types of traction. Buck's traction. It's used for your fractured femurs. It will pull those bones together. It's there so it will prevent all those muscle spasms. What is our goal? Well, making sure you're monitoring neurovascular signs, making sure that you're documenting how much weight is on the end of, that pulley, keeping that pulley and weight free flowing. It is on 24 hours a day. It does not come off. You take it off, those bones will go another way. Those muscles will pull in. And again, you're starting from ground zero. So keep it that way. Now, Russell is Bucks, but it just has a little piece of tick cloth that goes underneath the femur just to hold it. It's the only difference. And then, of course, I told you the Bryant's traction. Again, it's all about that. And you can see the butts up a little bit, and it's that right angle that's going on. And then we have some of the ones that are what we call more bone traction, where it goes into the bones. Now, what do we check and what do we teach our children to check after they've had a cast applied? Well, it's the 6 P's. Where's the pain? Is it getting worse? Is the color of the toes, if that's where the cast is it pink? Is it getting pale? Can we feel a pulse? Does the pulse go away? Is there numbing? They can't move it, paralysis? Is there pressure building up? Those are things that if they're getting worse, they need to come back and need to be checked. The goal of the cast is keep it dry. I've had many kids get one on their arm, go home, pull on their bathing suit, and jump in the pool. I had one little boy who did it 2 times in one day. I thought the mother was going to go crazy. What do you think you're doing? Back to the emergency room, because a wet cast is a dangerous cast because it can grow, disease underneath, algae, etc., whatever. So it must be changed. We need to teach them when the cast is on, elevate it, wiggle their toes. Again, no powder, no lotion, and a cool hair dryer is good. And sticking things underneath there, it could cause an abrasion, which could infect it, and we can't see it. Now, cerebral palsy is described as a permanent disorder of impaired muscle movement, hypertonicity, poor posture. These are the children that can't control their own bodies. Now, Some of them are milder and some are those that are more severe. Many of these children also have epilepsy. Many of them do have the ability to eat. Now, one of the things we have to remember, they don't have complete control of their muscles. So we need to have the head of the bed elevated if we're feeding them or sitting up. Give them the time to chew and to swallow because it will take longer. And these kids can aspirate easy. So to make sure that you're monitoring for that. So these children, what do we need to do? Take care of them. Well, early intervention helps. We have children that are cerebral palsy that are doing more than we ever thought they could do. They are, recognizing numbers and shapes and colors and stuff that we never taught before. And now we are, and I love that. Treatment. Remember all the medicines they're on, like phenytoin and gingival hyperplasia. Some of these have epilepsy too. So make sure we take care of their teeth well, make sure that they know how to do their medicines. Again, always safety. These children can't control their bodies, that they're in something that they are harnessed in properly. So they can't fall, they can't hurt themselves. And to put them in activities that they can be involved in. Maybe it's this big ball around the room and they can hit it. I mean, they're excited to do stuff like that. And again, all the therapies and always supporting the family. So know that there's always dosage calc. There are worksheets. If you don't got them, you let me know. I'll send them to you. There are always dosage calc videos if you want them. If you need any help, you want a one-to-one, you can just send me a message and I would be glad to. Can I help you with anything?
Thank you.